Okay, so can we be talking about methadone clinics and opioid treatment programs? So next slide. So learning objectives have a basic understanding of opioid treatment programs and OTP federal regulations and monitoring. So OTPs are outpatient programs providing, I won't read this word for word, but whole patient approach for recovery and treatment, includes medication treatments for, opioid use disorder that include methadone, buprenorphine, and naltrexone. And our multidisciplinary team is comprised of physicians, nurse practitioners, PAs, counseling and clinical staff, other medical staff, so nursing staff, and then front office and administrative staff. So OTPs are governed by certifications through federal guidelines. I should have read through some of these beforehand, but it's through the Department of Health and Human Services. We also are required to have certifications through SAMHSA, the Idaho Department of Behavioral Health, the Board of Pharmacy, and the DEA. And then we're accredited through Commission of Accreditation for Rehab Services, CARF, which we do. I'm not sure how often we do those, but we have to do those regularly. They come in and review everything. Part of OTPs is offering all 3 of the FDA-approved medications as options for patients. When a person comes in, an initial physical exam is done, and EKGs, we test for HIV, HCV, syphilis, do TB testing, and then we also include a CBC and CMP just for monitoring. We provide behavioral health therapies through individual and group counseling and case management, do some mental health services for co-occurring disorders, regular drug testing, and then we have a DEA diversion plan. Oh, next slide. So as part of the tips is there's no one-size-fits-all approach to OUD treatment. Many people with OUD benefit from treatment with medication for varying lengths of time, including lifelong treatment. Ongoing outpatient medication treatment for OUD is linked to better retention and outcomes than treatment without medication. Even so, some people stop using opioids on their own. Others recover through support groups or specialty treatment with or without medication. So why include OTPs as a treatment program? OTPs can prescribe methadone, buprenorphine, and naltrexone. It's the only type of setting that methadone can be prescribed through, since it's Schedule II opioid receptor agonist and can legally be provided to patients with OUD outside the context of hospital admission or certain other special circumstances. So the 3 different, just a little information on the 3 different medications. So methadone is a mu opioid agonist, buprenorphine is a partial agonist, and then naltrexone is an antagonist. So then some of the benefits, a lot of the benefits between methadone and buprenorphine are very similar. And then methadone can be initiated at any time. So even if somebody has used within hours of coming in to start treatment, methadone is an option because we can start it right away, versus with any buprenorphine products needing to have a period of abstinence and for the patient to be in some mild to moderate withdrawal, or through initiating microdosing. Naltrexone, people need to be opioid free for 7 to 14 days before initiating, and recommendations for methadone and buprenorphine are to continue during pregnancy and while breastfeeding, and naltrexone is not recommended for treatment during pregnancy. And the bottom, no empirical data indicate which patients will respond better to which OUD medications. Research demonstrates that MOUD can reduce mortality from overdose by up to 59%. Won't read all of that. Based on results of multivariable Cox proportional hazard models adjusted for age, sex, baseline anxiety diagnosis, depression, receipt of methadone, buprenorphine, opioid, and benzodiazepine prescriptions the 12 months before, and time during receipts of opioid prescriptions, withdrawal management, and short-term and long-term residential treatments. Yet few people who may benefit from these medications have immediate and sustained access to them. So OTPs provide comprehensive interventions, so that include the medications, counseling, services that are meant to be offered as a whole person approach for care, and ameliorate social determinants of health that contribute to substance misuse. Numerous studies have demonstrated that treatment with pharmacotherapy and counseling services can reduce overall health care costs for patients with OUD. Oh, next slide. Researchers have increasingly recognized how stigma toward MOUD contributes to inadequate treatment provisions. So compared to buprenorphine and naltrexone, methadone is the most highly regulated and stigmatized, which I have seen in the 10.5 years that I've been here get a little bit better in this area, still quite prevalent. Stigma from treatment and healthcare professionals has a negative impact on treatment access and quality of care. Primary care providers' stigma towards MOUD is associated with lower support for policies intended to increase access to treatment, even when treatment is available and accessible. Providers who stigmatize MOUD may fail to prevent methadone as a legitimate option, which is unfortunately something we see quite often. So some key points: MOUD works, opioid treatment programs work, and really what's utilizing whatever option works best for patients. And I think that's the big thing, because a lot of times Suboxone is far more accessible, especially in much more rural areas. And I know there's still a couple states out there that don't even have methadone or OTP treatment programs available. So, and Suboxone is not always effective for every person. That presentation was a lot shorter than I had anticipated. But if there's questions about, I know there's typically a lot of questions that come up specifically about methadone, safety, monitoring, and I know some federal guidelines have changed since COVID. There are some of the requirements that have loosened up a little bit. One of the nice things about OTPs is we do have the ability to monitor more closely. Patients are coming in more frequently. We're able to keep closer eye on patients, provide a higher level of care for patients that aren't doing as well, even with Suboxone or buprenorphine products out in the community, maybe needing a higher level of care, more supervision.
Thanks, Brenda. I know there's a lot of different questions kind of about this topic, and so I would love to just kind of open it up to having a nice big discussion here. I know I know our panelists have a couple questions, but if you are an audience member and you have questions, please also just use the raise hand feature and we'll call on you and kind of go through that way, but we can really just have an open discussion about these topics. So Lucy, do you want to go first?
Sure. One of the things that I had put in the chat was what Brenda was kind of finishing up with there, which was and maybe we could touch on some of the regulatory changes that occurred during the pandemic, what we observed with those changes, like from a data standpoint, and what has been kept and what has been changed. And I can share, I'm happy to share too, but Brenda, I wanted to give you the opportunity first and not take your time.
So some of the regulations, time and treatment, and illicit use were things that, even if it were marijuana use, some of those guidelines have been a little more flexible. And when I first started 10.5 years ago, the criteria was, they had to meet a certain 8-point criteria. And I can't think of all of them right off the top of my head. I know I have a list of them somewhere, but they needed to meet an 8-point criteria prior to being able to be eligible for take homes. And the amount of time it took for you to earn take homes. So it used to be in the first 90 days, you could only get a maximum of 2 total take homes during that time period. And then, oh, I can't even remember. Then it was oh, here it is. I have to look at it because it's changed. So, yeah, in the first 90 days, they could get 1 treatment take home a week and then a holiday or clinic closure take home. So a maximum of 2 take homes per week when they first started treatment. From 91 to 180 days, they had to still meet the same thing. They could only have a total of 3 take homes. At 181 days to 270, they could have a total of 4 take homes. And then it took 9 to 12 months to be able to receive a week of take homes. And then at the 1 year mark, they could get 2 weeks of take homes. And it was 2 years before they could get a total of monthly take homes. Obviously, they needed to also continue to meet those guidelines. I have those right here. So the 8-point criteria was no recent drug use, attending the clinic regularly, having no serious behavioral problems, no criminal activity, have a stable home environment and good social relationships, time in treatment, being able to safely provide storage for their medications, and that the rehabilitative benefit outweighed the risk of diversion. And so I don't know exactly all of the changes. We have modified our take-home policy, which is still a little stricter than what the federal guidelines call for. And what we saw during COVID was, so people with marijuana use didn't qualify for take homes because it was illicit use, could potentially lead to relapse of other substances. When COVID happened, to reduce the number of people, we did start giving take homes for people that were stable in other areas. Marijuana use was one of those things we just kind of put on the back burner and just monitored for. I don't have right off the bat, and I wish I would have written it down or pulled it up, but our current take home policy, so for phasing up to earn take homes, is in the first 0 to 30 days, people can get up to 2 take homes. And everybody typically qualifies, all of our patients qualify for that right off the bat because we are closed Saturdays and Sundays. At the 31 day to 90 day mark, they can get 3 to 4 total take home days. Once they hit 91 days to 120 days, they can earn a week of take homes. And then 121 days to 180 days, 2 weeks of take homes. And then anything over the 180 day mark, they could receive up to 27 take home doses. So coming in once a month.
And now, is that still, and those are your rules now? Because that was one of my understanding was one of the changes was that it had previously been a max of 14-day take homes, no matter how you slice it, no matter how long you were in treatment. So it was my understanding that that increased from 14 to 28 during the pandemic. And it sounds like that is a change. Is that a change that was kept post-pandemic? Because I haven't worked in a methadone clinic in a while.
Yeah, and we didn't loosen up our guidelines as much as the feds did initially, and I would have to see if I could find. They've loosened them up quite a bit more than that. I think within
Yeah.
2 weeks, people can start getting up to a week of take homes per the new federal guidelines. I think one of the things we saw, and I don't know about other clinics, the data that they came up with showed that people did better with more take homes, whereas what we happened to see during COVID was more and more people were ending up misusing some of the take homes, um, running out of their medication earlier, or because they were home all the time, kind of dabbling with other things and coming up positive for other substances. And that wasn't for everybody, but we did see a little bit more of that compared to what the data showed outside of here. So we've loosened up our guidelines to be more, to be a little looser,
Hmm.
but still are a little, probably a little stricter than what the typical federal guidelines are actually set at.
I see. And I also wondered, as I understand it, one of the other changes, I'm very interested in this. One of the things, as I understood it during the pandemic, is patients were actually able to do telehealth visits with their OTP. And as I recall, like some, and I know just enough to be dangerous about this, but as I recall reading about that, that was associated with a much higher like patient satisfaction with treatment and like a 10 or 15% increase in retention rate. Is that a change, like the ability to use telehealth services? Is that a change that was kept, or is that something that has since gone away since the pandemic has ended?
We still do use it. So Dr. Nina, I don't know if she's on. I know she was going to try and join. Dr. Nina, so we do have a clinic in Pocatello. We do not have a provider that is in that area.
Okay.
So hi, Nina. Uh, so we don't have a
Hey
provider
guys.
specifically located in Pocatello. Dr. Nina does a lot of the Pocatello telehealth intakes. We have an amazing nursing staff and just treatment team out there, front desk staff. They're very diligent about gathering additional face-to-face data that they're able to provide, since patients are seen via telehealth through there. I Luke and I also will see patients via telehealth in Pocatello at
Okay.
varying times, or Cheryl. Um, Sometimes we'll see patients if we don't have a provider in Nampa and the provider's in Boise, but we have an intake that comes in and needs to be seen. We can do them via telehealth. So that is something that has continued.
I'm glad to hear that because this seems to be a condition where even when we have super compelling data, we being the collective society, tend to choose to do the opposite thing, which would never be a palatable thing for something like breast cancer or heart disease. We would never have something that increased retention or improved survival and say, well, oh well, we're going to go back to what we usually do. So I'm glad to hear that telehealth is an option now too. That's great. Thank you
Yeah.
for answering my questions.
And then I think, well, and I don't know exactly when Twin Falls is going to be opening, but we will be opening a clinic in Twin Falls. Uh, Things are in process. It sounds like they've secured a location, and so now it's just getting through all of the other stuff. And most likely, telehealth will be continued via our providers, Dr. Nina, Luke, myself, and Cheryl.
Yeah, I'd like to comment on that. There are some changes that are happening. I think that, and I'm not completely up to date on them, so don't quote me. It's something that I also need to look into. There are some continuing allowances per, the initial public health emergency that are ending, but a lot of states and a lot of states have now made their own laws that are outside of that have allowed telehealth to continue, and they're writing their own state laws that allow telehealth that are not related to the public health emergency, which is awesome. I mean, there are, sometimes, of course, when it can be super beneficial to see a patient in person, but patients have gotten so comfortable with, being on Zoom or being on remote audio, visual, that they're comfortable, opening up and talking to a provider as if they were in person with that provider. And it has incredibly increased access to care. We've seen that. Pretty significantly. And patients do, they love it. Unfortunately, for so many patients, right? Our patients aren't, they're working long days. They have kids at home. They might be single, parents and they can't take an entire day off to go to a visit, and miss an entire day of work. And so I'll have patients that can take just a short period of time and they can hop on, their phone or their computer to do their visit and they get care. So it is absolutely something that is beneficial.
I'm really glad to hear that. Thank you for sharing that because this has been one of those things that I have for years thought like we collectively follow these recommendations and it's not really based on data or science, right? Like this whole mechanism by which people access methadone for OUD. And I feel like this eventually we will get to where clozapine is, where we don't have all these barriers up to get people connected to these treatments that they really need. So I'm glad to hear that. Dr. Nina, do you find that Idaho's retention rate in methadone clinics for OUD, is that similar to what we see nationwide, or do you find that we kind of fall maybe below or above the national average in terms of retention?
Gosh, Lucy, I don't have that data. It's a really good question, and I think that we'll actually look into that. We do have some good statistics available to us, so that's something that we'll look into, but I don't know the data off the top of my head. I would say that it's pretty reasonable. I mean, I'm biased, obviously. We have a really good team. Our team has been together for a long time. We have an extremely low turnover rate for providers and staff. And so a lot of our patients we've known for a long time. They know who we are. They look forward to coming and seeing us. We have a pretty darn good retention rate for our patients in general, but I don't know how it compares.
Yeah, I'm not sure either.
I'm hogging all the questions, so I'm going to be quiet now.
No, those are great.
Sorry.
Amy, oh, go ahead, Todd.
Yeah, for some reason I thought it was 12:30, like the curbside, and then I couldn't get on. But sorry about that. So you guys might have talked about this already, but so not this year, but last year at the ASAM conference, there was discussion about a bill that would allow board certified addiction medicine doctors outside of an opiate treatment program to prescribe methadone. And they talked about it like it was going to pass right away, and then it just kind of got dropped. The whole thing got dropped. So I don't know if anyone knows where that's at these days. Obviously, that would have a huge impact on this whole thing. Um, so I don't know if you guys have any more information.
Yeah, I haven't heard anything about here. I know I've had come across some recent articles where it's something that's been up for discussion and they're hoping to eventually get to because there's statistical, like a lot of data from Canada that having certified addiction specialists prescribing and monitoring methadone outside of an OTP has shown to have a positive impact, not only on retention, but just follow through, overall reduction in use in general, just because, an OTP, even with the changes in some of the flexibility and some of the guidelines, still coming in every day, even if it's for a week or 2 weeks, especially when there's, think about right now, Idaho has 6 clinics. So BHG, or used to be Center for Behavioral, they have 3 clinics in the state. We currently have the 3 clinics. We're going to be opening one in Twin Falls, but there's just a lot of area that's not covered. And being able to drive hours, like Nina said, driving hours to get to a clinic, especially if you're having to do that every single day, is not feasible. And a lot of our patients have, well, not a lot. There's a large percent of our patients that they've done Suboxone, they've tried it multiple times, either it hasn't worked for them, they've gotten up to 24, 32 milligrams, they're still having some cravings, withdrawal symptoms, or there's just that difficulty of, oh, I forgot to take it for a couple of days, or I couldn't get my prescription filled right away because of an issue at the pharmacy or whatever it was. They relapse, and then being able to restart Suboxone is far more difficult because of that waiting period. And we're seeing with fentanyl, and I mean, just in my experience here, it's taking a minimum of 48 to 72 hours of abstaining from any fentanyl use to reduce the risk of precipitated withdrawal. And even then, people are still struggling. And once somebody experiences that, they are far less willing or likely to try it again. So they have gone that route, either done well for a while or continue to have withdrawal symptoms, cravings, and continued use. So it ends up being a big thing. And I know, I mean, in the past, we had somebody driving from Twin Falls to Boise. We actually still have a patient that drives from Twin Falls to Boise. Thankfully, she's gets 2 weeks of take home, so it's only twice a month that she's coming in. But at one point, she was having to come in daily, and that is a significant part of somebody's day to get in. So I have heard that, Todd, and I haven't heard anything as of late. Just I would say a couple months ago, an article came through that I read they were looking into that and kind of pushing more for that here in the US because they've just seen such an improvement in care and reduction in other use and overall safety by having prescribers in the community that can prescribe.
Great, thanks.
And I encourage everybody on the chat to be an advocate for improved access because one of the things that I say to people about this topic is I remind people like if you work in a pharmacy, like the highest alert group of medications is insulin. Okay, you can buy insulin over the counter without a prescription. We don't see this kind of restriction to accessing things like insulin or even aspirin. Aspirin would be a prescription only product if we discovered it now. And I always encourage you to make this kind of analogy when you're talking to folks, especially if they're not medically trained or they don't understand what you're saying, to kind of make those parallels and remind people that we have lots of dangerous drugs that we use to treat conditions that help people live longer. And this should be no exception. And I highly, highly encourage you to advocate for improved access.
Thanks, Lucy. I know Amy has a couple questions, and then Peg also let me know that she has kind of a methadone case question as well. So, Amy, let's go to yours, and then Peg, we'll turn it over to you.
I just wanted to know, and Brenda or Dr. Nina, like, can you kind of walk us through like what it looks like for a patient just starting? Like they come in and then like what's the intake look like? Like what do they have to do?
So I mean, I know Nina works remotely, so hers is a little different, and it's been a little while since, unfortunately, she's been on site with us. But so the typical intake process, the person comes in, our front desk staff kind of go over things, review, do a pre-screen, figure out what's going on, make sure they're going to meet criteria for treatment. Then the patient then will see one of our nurses. The nurses get an EKG, do vital signs, do a TB test, draw labs. So like I said, we test for HIV. I think HIV, syphilis, and Hep C are required. But we also, in addition, draw CMP and a CBC just to check out any other potential issues that might need to be addressed. After that's completed, then they meet with the provider. We go through, whoever the provider goes through their use history, kind of what's going on, what their current pattern of use is with any and all substances, just so we have all of that information. And then kind of go through, and I know that we are really good about offering. I'm never going to tell a patient what medication they should do. I think it's important to make sure we're educating the patients on what all their options are, and then supporting them in whatever that decision is. A lot of times when they are saying adamant about Suboxone, but they can't go more than 12 hours without using fentanyl, I do make sure they're aware that Suboxone may not be an option at this time. What we may want to do is start with methadone because we can start it right away. And then once they are not using other substances, if they're still interested in transitioning to Suboxone, that is something they can meet with a provider about. We can talk about the different options for transitioning and support that transition. We don't very often do Vivitrol just because it's rare that we have a patient that comes in that has been abstinent from all use. But that is something that I know I bring up, especially as people are tapering, as an option if they're interested in doing that once they've completed their taper, feel like they're doing well, just as an extra support. Some people feel like, okay, if I have this, even if it's for a month, then just that extra support and reducing that risk if something were to happen and they did relapse.
I'm
So,
just going to throw one thing out, Brenda.
yeah.
As far as people on fentanyl and starting Suboxone, there's so many different ways of doing it, but one way is doing macro dosing, right?
Mhm.
And you don't have to wait nearly as long.
Yeah.
So I just want to make sure people know. And
Yeah.
surprisingly, the rate of was has been kind of unexpectedly low, with macro dosing. They talk about this a lot in the ER literature. Um, but just want to make people aware of that.
Yeah. We don't typically offer that as something here because even with Suboxone patients, when they're first starting, we do want them to be dosing every day,
Yeah.
monitoring them, making sure we're adjusting doses appropriately, having eyes on them regularly. We have also changed up our Suboxone. Our Suboxone policy was far stricter than what was in the community, and we've definitely made changes to that just to improve access to care to our patients, um, which seems to be over the last few months since we started this seems to be working out really well. Um, so, and
Can I?
then,
Oh, sorry.
yeah,
I was
and
just
then
going
I
to
was
ask
gonna, oh,
Dr. Palmer on the macro dosing that you're talking about. Is this like in the ER? Are they doing like a cows protocol? Like, are they dosing them with a 8 milligram strip and then repeating a cows and then giving another if they score a certain threshold? Or are they just like empirically giving larger doses?
Um, I think they're empirically giving larger doses,
Okay.
like 16.
Okay.
There's so many different ways of doing it.
Okay.
But of course, they're in the ER, they're being monitored closely. So they have that advantage, which we don't have. They're in a monitored bed. And so different ball game. But they are doing that more and more, I believe.
and we can do that with some of our patients that had come in and they're like, I haven't used in 3 days. I really want to do Suboxone. Great. Because we're dosing them in clinic, we try to do it so they can dose, kind of see how they're feeling 45 minutes or so later. If they still need another dose, I mean, I've ramped people up to 12 to 16 milligrams the first day because we're able to keep an eye on them. And I know at a doctor's office, that's not really an option. I think that's the other thing we're really fortunate with. We have a lot of staff. So that are checking in and able to monitor patients more closely. So we can do those things.
I'd be interested in is Jake still on, Harris?
He had to leave early to catch a flight.
Oh, okay. I was just interested in whether or not he's done macrodosing with patients on fentanyl before. I don't know if
So,
anybody else has experience with that.
so Todd, with the macrodosing on somebody using fentanyl, is that how long do you have them wait with like abstain from fentanyl use before starting?
Yeah, I mean, there's a lot of different theories about that. I'm remembering one lecture I was at as an ER doc. She said, the first physical sign I see of withdrawal, I load him up on Suboxone,
Oh,
like without waiting for a particular. I'm not saying that's the right way to do it. There's, it's really a moving target. There's a lot of different ways of doing it, but that just the general principle of macro dosing with 8, or I think it's generally more like 16, people that have been on fentanyl, they've just found that the precipitate withdrawal rate is actually quite low, and people seem to do okay. And And as far as when they do it, I've actually never done it myself. But I remember one ER doc talking about, just she waits for any sign of any physical sign of withdrawal, she'll load them on Suboxone.
That's good.
Thank you. Maybe we'll have to do a session on macro dosing of Suboxone
Yeah.
then.
I
Sounds
mean,
like a new topic.
we do have that, because the fellow, I'm blanking on his name
Are,
right now.
are you talking about the emergency treatment with buprenorphine topic?
Well, I think Andrew Klobuchar, if I'm saying that
Mhm.
right. I think he did a couple of sessions on this, and I think that included macrodosing. So
Okay.
there's a lot of different ways of doing it. Like I said, it's kind of a moving target. I mean, people are putting patches on it. They're putting transdermal. There's a lot of there's a lot of different ways of doing it. Um, uh, and I think Andrew covered some of those in his last talk. But I think we're going to have another one coming up, right?
Yep, that's
Yeah.
right. November and December, we have Dr. Cloberdon's coming back, and he's doing two different topics on fentanyl. I think one is treating fentanyl in the OUD era, and the other is find here detoxification of fentanyl versus opioids.
Oh,
So
that'll be good.
I'm assuming he'll cover it then.
Yeah, he will. Yeah.
Good.
Yeah, great. Well, Peg, I know you had a question specifically about a patient on methadone, and I would love to kind of just turn it over to you and get some feedback from our panelists here.
Several months ago, I presented a patient who was on fairly high dose methadone and for pain, and I wanted to switch her to buprenorphine. And I was advised by this committee to do microdosing. So we have been doing microdosing. I want to say we're at almost 8 months with this patient.
Well,
My biggest problem has been nausea with the buprenorphine. And the problem was she was taking all her buprenorphine at once in the morning, and then she vomited the rest of the day. And so she now takes it 5 times a day. And we're slowly titrating up on that. But we've had lots of pauses in that care. The most recent pause was just this week. She kept falling. In 1 week, she fell 8 times. Why are you falling? Well, she had knee replacements, and a piece of her hardware came loose. So we're not backing off on anything, but we are staying at the dose. She's going to see a surgeon about her hardware in her knees. But when I'm trying to use buprenorphine, nausea is my biggest barrier. Does anybody have some advice on how to manage that nausea?
well, let me say first of all, 8 months that's not you don't do microdosing over 8 months. Microdosing is done generally. It's done over 7 days. However, sometimes when people are on very high doses of methadone, it can be stretched out to maybe a month, but not 8 months. The whole theory behind microdosing is it's actually not even called microdosing anymore. It's called low dose induction. The whole theory behind it is you continue them on their methadone. You continue them on their methadone, and then you're titrating up the buprenorphine until you get to a level, whether it's 8 or 12 or 16, and then you stop the methadone. So we're not giving methadone and buprenorphine for 8 months. I hope you're not doing that. This should only last about 7 days, and like in some cases, it can last a month. If they're on like over 100 of methadone, then it can be stretched out. But I'm kind of curious as to what kind of doses are we talking about? You said 5 times a day you're giving her buprenorphine?
Yeah, I'm giving her 0.5 milligrams 5 times
So
a
you
day.
said 0.5?
0.5. I'm having it
0.5.
compounded.
I see. Yeah.
Dose of methadone is she on? Or what dose of methadone did she start at?
She is on, 40 milligrams a day.
And she's still on that?
She was on 60 when we started.
Is she still on
Now
40 a
on
day?
40. Yeah, she's down to 40.
Yeah, so that's I don't mean to be critical at all, Peg.
No, I misunderstood you. You said go slow.
Well,
So I've been going slow.
yeah, I mean, that's irregular, to continue both for 8 months. Usually, like I said, usually 7 days, maybe longer. If they're on like over 100 of methadone, then um, so she's only on so she's only on 2.5 milligrams of buprenorphine a day now.
Yes.
Okay, so um, you need to titrate her up to probably maybe even 8 or 12, and then just stop the methadone. Like you can't keep going with methadone. That might be why she's having the nausea. She's been on both meds for 8 months, and I would I would try to titrate her up slowly. There's a lecture that I did, Peg. It's in their files, and there's some really good regimens in there, just suggested regimens like first day is 0.5, second day is 0.5 BID, third day is 1 BID, third day is 2 BID. So that's what you do. You're slowly titrating up until you get into a target dose of like 8 to 12 or 16, and then you just stop the methadone. So I would try to get her up to maybe maybe 12, and then just stop the methadone. If you need to go up further on the bupe after that, you can go up to 16, but you need to get her off the methadone. It's been way too. 16 is a nice sweet spot because you get good protection. I mean, you get decent protection from fentanyl if they take it, but um, I don't know. I try to put people on. I don't know. I don't push everybody up to that, but she might do. I mean, she's not on a very high dose of methadone, comparatively speaking. I mean, someone told me once that raised the bottom, the average dose was 120 a day.
Oh, and it's higher than that now, Todd. With
Higher than
fentanyl,
yeah.
yeah.
So she's on a low dose, and in fact, she's on such a low dose,
Yeah,
Peg,
she's
that you
almost on an induction dose.
Yeah,
exactly,
you can
exactly.
almost just ramp her up and have
Yeah,
her even half dose the methadone. So I've done that a couple times where instead of going up every day, going up every 2 to 3 days. I did that with a patient that was on, I think she started out at 60 in methadone. And then when we hit about the end of the first week, she dropped her methadone dose in half. And then the following week, we just ramped her back up and she quit taking methadone. So,
Yeah, and I tend to agree. And I think you also are probably going to have, with that sustained use, you're going to have a fair amount of accumulation too. So you're going to get some self-tapering anyway. I think you'll be totally okay.
Okay.
so I would see what happens with the nausea once you do that.
Okay.
the
My
nausea
suspicion is
might
nausea will
actually
go better.
be a side effect of she's got just enough buprenorphine in there and methadone that it's putting her into some mild withdrawal that may actually be the nausea.
Right, right.
Okay.
And you can, and just so you all know, I know all of our providers are very open. And so if you ever have people that you just are looking for some recommendations on or to bounce some ideas off of, you're always welcome to call the office. We're here from 6 a.m. Well, providers are here from 7 a.m. to 12. The clinic itself closes at noon, but there's usually a provider. I mean, I'm usually in the office till around 2. Front desk may not be in answering the phone, but you can always hit the option to talk to a provider. And if somebody's not available, leave a message and we're happy to call back, even if it's not one of our patients.
I don't think I have your contact information.
I can put it in the chat.
Okay.
Thank you, Brenda.
You're welcome.
And I did just look back at those recs that we did send you, Peg, and I'm sorry that we did not send you a specific time, like long-term timeline of, I was just looking back at them and it did say go very slowly. And so, but there was no specific outline of what slowly meant. And so we'll make sure to be a little better about that in the future.
Thank you. I mean, it's going slow.
Yeah, a little subjective, right? We do also have, Eric, I'm wondering if you can find this, the low dose induction video on YouTube that Todd did. He does this every year for us and does kind of an update on low dose induction and how to do that. And so feel free to look at that video as well, because I think he gives some really good step-by-step exactly what to do for low dose induction. And we'll throw that into the chat. But thank you so much for giving us an update on this patient, and hopefully that goes a little better for you moving forward.
And I included in my email. So if there's ever any questions, you're welcome to email me. Nina, do you want me to throw yours in there too? Your email?
Yeah, that's absolutely fine.
Perfect. That way, we're usually really good about getting back to people because we want to definitely support the community, everybody in the community, and especially in rural areas where methadone isn't really available. And I know it's been a couple years ago, there was a patient somewhere, this was before Pocatello opened, where we had somebody transfer from another state to that area on methadone and was able to talk with that provider on steps to do to taper off of methadone and to do the transition to Suboxone. So thank you, Nina.
Lucy, you want to go ahead?
Yeah, and Brenda, I'm sorry if I missed you or Nina saying this. Would you just share? Because I have a couple patients on my panel who I'd like to refer. Can you just walk through what some of us can do to refer patients over to y'all to get them started in the methadone clinic or bupe clinic?
Yeah, so we are very fortunate. We typically have at least one provider in an office that's available to be seeing patients at any of the locations. We have designated spots so patients can just walk in. They don't have to call and make an appointment ahead of time. They can show up, preferably before 8 a.m., just so that way we can get through, because it's about an hour to an hour and a half intake process by the time they fill out the paperwork, go through all of the stuff with front desk staff, getting all that information, going through signing all the consents and going through basic information, and then they'll see the nurse and then they'll see the provider. So either that or they can call whatever location they'd like to and call and schedule. If you guys send fax referrals over
Okay.
the office, our front desk staff gets those. They immediately follow up on any of those too by reaching out to the patient and trying to get them on the schedule.
Okay, and I'm understanding correctly, they don't even have to have a referral.
Nope.
That's awesome. Okay, great. Thank you for clarifying.
Yeah. And if they call, the front desk will go over any of the things that they need to make sure. Usually the number one thing is a valid ID. If they have insurance, bringing that information. We also can do Magellan funding. So if we have patients that don't qualify for Medicaid but don't have other health insurance and meet the criteria, they can qualify for Magellan funding, and that covers their treatment here. So, but we try to get any new intakes in, or people that say they've left treatment for an extended period of time, and whether they moved or there's something happened and they come back, we want to try and get those patients in the exact same day. So we work really hard at getting those patients seen because we don't want to lose them.
Awesome. Thank you very much.
Mhm.
Oh, sorry, Vanessa, did you have something? I saw you come on and off mute.
Sorry, I actually just wanted to say, so one of the other options that we have available for a referral, sometimes, depending on when you meet with your patients or clients, we have a submission form on our website that I highly recommend if you have someone in front of you in that moment wanting treatment, say it's an evening or a weekend. I highly recommend filling that out. That way we have the patient's information and we can continuously contact them for up to about, I believe it's 90 days, 60 to 90 days. That way, at that time, if they change their mind for the next day, at least we continue to touch base with them. That way they don't forget we're there.
Good, great to know. Thank you very much.
Thank you, Vanessa. There's certain things. So Vanessa used to also she was one of our customer service gals and is now our community outreach program director. So she has a lot of good information. I did not know that. So thanks.
Yeah. So
I don't get on our website very often and look.
and we're working on it. So it's currently being updated at the moment. But if anybody ever has any questions or wants to get in contact with someone from the clinic, and anyone's welcome to contact me. Sorry, I'm looking that way. But yeah, I'm always available to meet, to have conversations. If you guys have questions and you need to get in contact with one of the providers, I can always be a good bridge for that. So anyone interested. We also, for our Twin Falls location, if anyone is in that area, we will be having an open house. So if that's something you guys would like to be involved in, please email me. I can put my email in the chat if you'd like to be part of that too, and I can reach out to you once once we know the opening date.
Vanessa, that would be so awesome if you could put your contact information into the chat. I think that would be great for a lot of folks who are in that area and who might want to refer. Thank you for giving us that information. Are there any last questions that we have for our folks here who are presenting today or our panelists?
I don't have any questions, but I want to make one more comment to Vanessa, just really quickly. And I don't know, this may not be relevant at all, but I know Idaho State University's health clinics in Pocatello are also trying to provide further buprenorphine services. So I don't know if there is an opportunity for collaboration with that site with them, but if that's something that might pique your interest, let me know and I can connect you to the people who are doing that at Idaho State. There might be a good opportunity for collaboration there.
Absolutely. We have a clinic out there. So I'll send you my email. And if you just want to shoot me a quick email, then we can kind of discuss that.
Sounds great.
Thank you.
Great. Thank you so much. This has been really wonderful. I'm really glad that we got to have just an open discussion with everybody. I think oftentimes that's what we're missing at Echo is the time to just talk and discuss topics. So thank you guys for all being part of that. Thank you, Peg, for kind of doing an impromptu case presentation for us. That was really awesome. And thanks for all the feedback from our panelists. Okay, and Vanessa, I see that your email is in there. So if you guys are interested in contacting Vanessa, make sure you copy that over. She's got her email and phone number. We are going to be back in 2 weeks on Thursday, October 23rd, when we have Dr. Philip Daly with St. Luke's Health System. He'll be presenting about pregnancy and opioids. We also have some folks from Idaho Department of Health and Welfare who are going to give an update on a new program that they have available for pregnant women and substance use. So just make sure to sign up for that. Again, these sessions for the rest of the year are new. So you do need to go and enroll in all of them in order to make sure that you can get in before the session starts. So make sure you do that, and we will see you guys soon. Have a great rest of your day.
Thank you.